The REVEL trial was a study done prior to the immunotherapy era, and this was looking at docetaxel versus docetaxel plus ramucirumab, which is an IgG1 monoclonal antibody to the extracellular domain for VEGFR2. And what it showed was that the combination of docetaxel ramucirumab was superior to docetaxel for progression-free and overall survival. So it definitely got accepted as a salvage second-line therapy. And the nice thing about this is it was accepted for both patients with adenocarcinoma as well as squamous cell carcinoma, so all histologies. Now again, this was done in the era before immunotherapies, so we don't really have much data yet about what happens after you've given immunotherapy or immunotherapy chemo combination and what the data would be with docetaxel ramucirumab. However, we do think that this is an effective regimen and that it may also, due to subset analyses, be quite effective in patients who have rapid progression after their frontline therapy.
The REVEL trial was one of the largest second-line trials we've had in non-small cell lung cancer. More than 1,000 patients randomized to either docetaxel or docetaxel ramucirumab. And of course, we saw the addition of ramucirumab, an anti-angiogenesis drug, did translate into a meaningful improvement in response rate, progression-free survival, and overall survival. I think we've learned additional insights from some subset analysis from this trial, looking at patients that had rapidly progressing disease on the induction regimen prior to them receiving the docetaxel or the docetaxel ramucirumab. And if you look at the subset analysis in these patients, patients who had progressed on frontline chemotherapy less than 9 weeks or 12 weeks or even 18 weeks, looking at those three subsets, all of these patients seem to derive a meaningful benefit adding ramucirumab to docetaxel as a second line. And I think that's a little surprising because these are patients who don't do well no matter what you do. These are patients who are getting chemotherapy, they're not responding, their tumor is growing. It's very hard to salvage them and add an agent that may translate into improved survival. And we saw this. We saw that adding ramucirumab to docetaxel, when you compared it to docetaxel in this specific subset of patients, there was an improvement in survival. I think we have to go back and understand why this is happening. Is VEGF, this is the pathway that ramucirumab is interfering with, is that highly relevant in this aggressive tumor biology? And by adding the ramucirumab, you're improving outcomes for these patients? I don't think we've completely ironed out the answer scientifically. Nevertheless, we do have the clinical data. And I think because of that, any patient who is rapidly progressing on a frontline chemotherapy regimen, they're in trouble. And I think you've got to give them the best second option available. And based on the data and based on the subset analysis, I think that is docetaxel with ramucirumab.
The subset analysis from the REVEL trial, looking at patients and how quickly they progressed and what their responses were to the ramucirumab docetaxel versus docetaxel, I think is very thought-provoking. Again, it was an exploratory subset analysis, but it did show that patients that have rapid progression do benefit from the combination of docetaxel ramucirumab. So if I do have a patient who progressed rapidly after the frontline treatment, I definitely have used in my practice the docetaxel ramucirumab and have been able to reestablish control in some of my patients. So I think that this is a very viable and reasonable salvage therapy in our patients. Again, we do need more data about what happens after immunotherapy, but for right now, it is something I am doing in my clinical practice. The REVEL trial was actually conducted in the second-line setting for any histologic subtype, and it showed a superior PFS and OS across all the histologies. So docetaxel ramucirumab can be safely given in any histologic subtype. Now, although the REVEL trial was a second-line trial, I admit that I have done it in third-line and sometimes even fourth-line. And so this is a very reasonable regimen. You can give it second-line and above in our patients who have progressed from a frontline regimen.
Based on REVEL, docetaxel with ramucirumab was shown to be superior to docetaxel alone, both in squamous and non-squamous patients. So I don't worry about tumor type. I would use it in both. And it produced a survival benefit, in the 0.8 range. It wasn't the biggest benefit in the world, but it was better. And it was also shown to be safe, and concerns, in the squamous patients with bleeding were unfounded. So that is the standard of care. It sometimes isn't used as much as it could be because its approval occurred just as immunotherapy was coming through, and everyone's very interested to use immunotherapy. But now that immunotherapy has moved to frontline, we need to have second-line options. Patients come in, good performance status, there's things that we need to do for them. So I think that's very important.